Yeah, we're good. We're already live, so everything should be good. And the setup of the other room for next will be just the same. Everything's the same? Okay, we're not going to adjust the chairs or anything?
I don't think so.
Sometimes we did once, but I think that's fine. Because the good thing is we're actually starting at 10:30, so that gives me a bit more time to set. Because I want to put the phone like in the middle. Because people will always be in the back.
Yes, we were. Yeah, we'll do that. Don't worry about
Good morning and welcome to the first grand rounds of 2019. And I would like to start with acknowledging that we are meeting on the traditional and unceded territory of the Musqueam people, for which we are grateful. We have some announcements. I'm going to just start with a couple of announcements of, there's no grand rounds in February because that would fall during reading break. The next grand rounds after that will be March 25th, I think. And I want to have a quick announcement of a very exciting initiative that we all want to support. So, Julie.
Thank you so much. Hi, everyone. My name is Julie. I'm a first-year MPH student here, and I'd like to briefly share with you an exciting event that's coming up on Friday, March 1st. So that's the date of the SPPH Exchange 2019, which is an annual conference held here at SPPH to share about research and innovation in public health. The theme of our conference this year is Transforming Rural Health, as you can see the title there, and we'll be showcasing some speakers, panelists, and workshops about research and initiatives combating inequities in rural regions. So we really look forward to being able to see everyone there. We'll be having a networking session, a couple posters, and a social as well. So it really is an opportunity to create some dialogue, knowledge exchange, and to meet people in SPPH and at the broader UBC. So the registration for our event is open right now. You can find us on the Eventbrite website or on the mobile app for Eventbrite. We are also putting out a call for posters, so if you have some research around public health in general and maybe would even like some funding getting those posters printed, we do have some funds available. You can contact us at spp.exchange@gmail.com. Myself and a few members of my team will be scattered around here and we'll be hanging around a bit afterwards as well if you have any questions. And I really look forward to seeing you all there on Friday, March 1st. Thank you.
Okay, so on with today's grand rounds. So I'm going to be introducing Gina, who will be introducing our speaker. This rounds has been in the planning stages since September, and we were absolutely delighted that we could leverage the presence of Dr. Martin in our part of the world to come and give us the a rounds presentation. So I just want to spend a couple of sentences saying we know Gina, a person who needs no introduction, But for those of us who are hanging around the SPPH building, where Gina hangs out normally is between here and Women's Health Research Institute. She's a Tier 1 Canada Research Chair and is doing amazing work on adolescent and other health issues. So with that, I'm going to let Gina introduce today's speaker.
Thanks. Thanks so much. Good morning, everyone. We, my colleague Mark Ansermino, who many of you know from BC Children's Hospital, and I were really delighted to co-host for the first time yesterday the first annual UBC Center for International Child Health Global Health Conference. It was a great success. We had over 200 registrants, and I would say at least 75% were students. So it was really marvelous to see the energy in the room. And we were fortunate to convince Dr. Keith Martin to come and be our keynote speaker yesterday. So we thought we'd take advantage of Keith being back home in British Columbia and invite him to give rounds. Many of you will know Keith from his role as a Member of Parliament in Canada, but right now, and since 2012, he's been the founding executive director of the Consortium for Universities in Global Health. So this is a organization of over 170 academic institutions from around the world, and what it does is harness capabilities and energies, research, advocacy, education around global health. Keith, as you guys know, has a very impressive CV. He was a member of Parliament, served on many parliamentary committees, had many roles both in shadow cabinet and as a member of the Queen's Privy Council. As well, he was involved in many diplomatic missions to many of the key hotspots around the world. Right now, he is based in Washington, D.C. in his role as executive director, but he also is on many other boards, including the Jane Goodall Institute. He's on the editorial board of Annals of Global Health and an advisor for many international and global health entities. So our theme yesterday was the role of academic institutions in global health. And so we thought that would be a good theme to continue on. So really delighted that Keith is going to present. After Keith presents, our own Dr. Peter Berman, who you guys know has a very impressive experience in global health and from his time over his career in Boston, is going to be the discussant and help sort of foster discussion on the role of institutions, academic institutions in global health. So please join me in welcoming Keith.
Good morning, everybody. Well, nice to see some friendly faces from yesterday, putting up with 2 days in a row. You're very patient people, that's for sure. It's a pleasure to be back here, Dr. Ogwe. Thank you very much for your kind introduction. Who here was at BC Children's yesterday? Fantastic. It was, for those of you who weren't there, it was really outstanding and wonderful. I really want to thank Dr. Ogwe, Dr. Ansermino, Simona, and the entire team. You guys did an outstanding job. It is no mean feat to put together a meeting like that, but it was done superbly, and that was the first. So there's going to be many more every year. That's what's going to happen. I'm really pleased to share the stage with Dr. Peter Berman here, so I'm to be with him. He's going to be discussing. Then we're going to sit up here and have a chance for us to have a discussion, so we get more out of that perhaps than us just talking. So we'll take your questions and respond to them accordingly. I have to say, as Gina mentioned, it's wonderful to be back home. And our office at the consortium sits about 1 kilometer, I can say 1 kilometer here, right? North of the White House. So of course, all of us know these are interesting and challenging times for our colleagues in the United States. But in the midst of those challenging times are great opportunities. And so I think that this is an absolutely opportune time for us as Canadians, as Canadian institutions, to reach out and work with our outstanding colleagues in the United States to address issues that we have in common in our own countries and also globally. So what I thought I'd do is just share sort of an overview of some of these big challenges that we're faced with today. And then, just use this. Thank you. Try not to break this. Great. No. Yeah, I touch computers. My stats, you can't break a computer. I do. All right. So look at some good news first, then we'll look at some challenges, then we'll look at some opportunities. So the good news. We know that there's been a staggering improvement in global health outcomes. Right? Look at the three major indicators of how you can address how we're doing health-wise. Right? The biggest improvement in longevity in history has taken place within our lifetimes. Reduction under 5 childhood mortality, and thank heavens maternal mortality too has been declining. But there's some big challenges, and Dr. Ogilvie, if you're aware of the outstanding work she's been doing on one horribly neglected area in the rise of cervical cancer, entirely preventable, but rising straight up with over 300,000 women dying per year. So there's big challenges that exist. That was the good news. But so some of the challenges. We've seen reductions in poverty, but there's big pockets of extreme poverty that still exist today. The demographic changes are not only in total number, the $2 billion challenge. Our planet right now is already oversubscribed in terms of what we're using in our ecosystems. We are living in an unstable environment. So, but we have the $2 billion person challenge. By 2050, we will have to find enough resources to feed and provide for another 2 billion people. How are we going to do that in this particular environment? It's going to require some colossal changes. Environmental degradation and climate change. Financing. We were talking yesterday about financing. The amount of money it takes to meet the Sustainable Development Goals is about $1.5 trillion a year. The amount of money we spend in official development assistance is about $150 billion a year. You know the discussions that are taking place right now, you watch the news, what are they talking about? They're talking about whether we can, all the countries in the world who are giving money, who are development assistance countries, whether they can meet that 0.7% of GDP as their target goal, right? Is that enough? If the countries in the world met that, that's not going to make a dent in the amount of money it's going to take, because we were already an entire order of magnitude away from funding the Sustainable Development Goals today. So even if we met those 0.7s, that whole discussion is really not terribly relevant to having the resources to meet our needs. That chasm is colossal. But where can you find it? A couple of interesting things. Did anybody see there's a WHO report that came out in the last 6 months in terms of financing that Anya Sukat and others wrote? Let me take a look at that. If you haven't, take a look at it. Because, yeah. But it is interesting, isn't it, Dr. Berman? Because it says that 86% of healthcare financing can come from within. Where is it going to come from? The money's lost in corruption every year. $1.5 to $3 trillion per year. Now that's not all, as some of our colleagues say, well, we can't go and blame low-income countries. Absolutely not, because we're part of that too. Those monies that are stolen go somewhere. They're not parked in the Congo. They're parked in London, in Vancouver, in Toronto, in New York, and in an array of areas in the world where you can hide your resources. I say this because we don't usually talk about this very much, but unless we're discussing this amount of money, this is how we're going to pay for what the world needs. So we have to start opening our eyes and perhaps looking at these issues that we don't talk about enough. The political instability and the rise of nativism. As mentioned yesterday in the talk, that if you want to look at how quickly a country your healthcare indices can drop rapidly, take a look at what happened in certain countries. Look at what's happening in Yemen right now. Right? You got a collapse in healthcare outcomes. I was in Zimbabwe some years ago, and at a time before the problems occurred under Robert Mugabe, the average lifespan was 55 years of age. Within a few years, you know what happened to the lifespan? It dropped to 32 for men and 28 for women in a few years. Those were a consequence of political choices and decisions that actually were a stake through the heart of the people's lives in that country. And they're not alone. You can take a long list and take a look at what's happening, and you can see that. And then lastly, in terms of challenges, something we don't talk about, and we were discussing yesterday, it was the essence of the conversation. It wasn't the issue of weak political institutions. So what do I mean by that? If you look at the, oh, this is the wrong one. Okay, that's okay. If you look at the world's, different side presentation, but similar, it's okay. Sorry, that's okay. That was must be my mistake, but that's okay, it's similar. No, it's my fault. That's okay, this is all gonna work out just fine. You have to have that attitude working in Washington these days, let me tell you. If you look at the countries that are pressingly, persistently poor and unstable, what is the common denominator that you find with these countries? If you look at any of these countries, and I say this to our colleagues down south, that stable countries have stable, effective public institutions. You cannot have a stable, effective country that can deliver public goods in a responsible way without having the public institutions to support that. If you don't have that, that's what you get. And none of these countries have that. So let's take a closer look at that. We often have these discussions about the sustainable development goals, right? So sanitation, building roads, providing hospitals and clinics, training healthcare workers. But if you were the leader of a country, or you're the head of a state or a province, what do you need to do to be able to deliver that? Whether you're here in British Columbia, or whether you're in the Democratic Republic of the Congo, what do you need? You've got to have a proper healthcare system, right? You've got to have public works, you've got to have a good environment system, education systems, but you've got to be able to finance that. So you have to have an effective finance department, right? You've got to be able to tax people, you've got to attract foreign direct investment, you've got to have companies coming in, you've got to generate those revenues. And that has to be effective and accountable to the governance structures below. The legislative branches, the judicial branches, the executive branches, and having a free and open media that can actually act as an oversight mechanism along with an effective, vibrant NGO sector, civil society. If you don't have that, if that foundation doesn't exist, you won't be able to achieve the Sustainable Development Goals. I would challenge anybody to show me how you'd achieve the SDGs without that foundation. But here's the interesting thing. What's the attention that we spend as we go further down towards that foundation? What's the attention that we actually spend in development assistance, in development, in global health? The further down you go on that list to that foundation, the less attention is spent on it. We don't invest or spend in those things that are important down on that foundation. We don't look at law enough. We don't look at judicial issues. We don't look at a rights-based mechanism towards global health. We don't look at how do you build up judicial structures so that people are not abused, so land rights are not protected. If you don't have that, predation can take place, and then you get instability, conflict, corruption, and healthcare indices go in the tank, right? So I'm saying that there's an opportunity for us, and I think here at the University of British Columbia, where you have an incredible opportunity where we're located geographically, and the incredible skills and assets and people and innovations that you have here, to kind of look at this, because not a lot of people are, to bring this together as an opportunity to lead internationally as to how we start to connect the SDGs all the way through this pyramid to the bottom. Through interdisciplinary training and education, through interdisciplinary research, and through service and advocacy. Nonpartisan advocacy, but advocacy nonetheless. Oops. Wow, this really was something totally different. So I want to take a look at another issue that's really important, is that on partnerships. This photograph shows a very large teaching hospital institution in a very large country on the continent of Africa. This hospital has been around for many, many decades. This country is very large. It will remain unnamed. And it's an institution that high-income country institutions have had ongoing relationships with for a very long time. We've had our students go there, we've had research that's being done there, papers have been written by high-income country institutions. On your left, when I visited the hospital, when I go to hospitals, I usually break off and ask the doctor to take me around so I can actually see what's going on. We do a little bit of a incognito walking tour, if you will, just to check out what's in the pharmacies, what are your stocks like, what's it like in Emerge, what's it like on the wards. On your left is the outpatient procedure department. There's blood on the floor. There's no soap in the sink. The equipment is dirty, blood-stained, and partially broken. You wouldn't have your dog go in there and get a treatment, but that's what they have. On your right is where the medical students and residents stay, where the windows are smashed out, the toilets are broken, and it's an incredible state of disarray. And this is in a city with 5 million people. It is the primary teaching hospital in that city. I give you this example is just for us to think through. We need an evolution in the relationships we have with our colleagues in low-income countries. We have to assert and work with them to make sure that our partnerships and collaborations are equitable and fair. And that both groups, high and low-income countries, are both getting benefits, but in particular, we have to look at ourselves and ensure, I think, that working with our colleagues, that there are long-term benefits accrued to them in the relationships that we have with them. Because as business as usual is not ethical and cannot continue. It's just not right. So we were talking earlier about the Toronto-Addis Ababa coalition that exists. We have a chance to look at something that's done right. Dr. Clara Payne is a psychiatrist from the University of Toronto who did a remarkable job with her colleagues developing a long-term relationship with the Ethiopian government and the Addis Ababa University to deal with the leading cause of disability in the world, mental health challenges. So if you have a chance, take a look at that model because it was sustainable, taken over by the country, paid for now by the government, sustainable, effective, equitable. So I challenge this as an opportunity for us to look at as time passes. Second to last, I want to look at just two things. One is in the issue of skill sets. At CUGH, we ask the question both of employers as well as students, what are some of the gaps of you grads? What are some of the gaps that you wish you had in training? So some of the things that we found from you graduates as well as the employers are the following. That we need to increase the skills acquired in academia through project management, monitoring evaluation, grant writing, understanding politics, communication, language skills, epidemiology, stats, and cultural competencies. These skill sets are transferable whether you are working here in Canada or you're working overseas. But we certainly need to do a better job, we found, to be able to increase the training and opportunities for students to acquire these skills. Finally, before I turn it over to Dr. Berman, I just want to say that here at the University of British Columbia, I think in Canada at large, there's a really great opportunity for us to be able to evolve the growing and changing world of global health through providing opportunities for interdisciplinary education and research, bringing in other sectors, bringing in the private sector, bringing in NGOs, working with governments to be able to work with them to deal with these challenges that we all share. I also would assert to work and reach out to our colleagues in the United States more actively in areas where they're having challenges, in women's reproductive rights, in maternal health. Maternal health is death rates are going down all over the world, except the US is going up. This is extremely worrisome to our colleagues there. The opiate overdose crisis taking place in the United States and the excellence in harm reduction that is being developed here. Dr. Tyndall has been a leader in this for a very long time. And I can say that for years, I've been in Washington for 6 years, trying to overcome some of the emotional obstacles that exist there to harm reduction. We have the great privilege of being able to showcase the work that's been done here in British Columbia to engage in harm reduction. So there are opportunities for us here in Canada, opportunities for us here at UBC to be able to reach out, to punch above our weight, to work with others, both in the United States and around the world, to do it in a way that's fair, sensitive, effective, and collaborative, to be able to address the global health challenges that affect us all. So that's my plea to all of you. And I'm going to hand it over to Dr. Berman, and then after him, we're going to sit here for a while and love to take your questions. So thank you for your patience.
So thanks to Dr. Martin. He just wrote my job description, I think, so I'll try to keep that in mind. So I thought what I would try to do just in offering some comments on his talk, and I have to confess I did review his slides, so some of these comments are going to be related to those. Dig a little bit into some of the specific issues that he touched on and raised, and then maybe we'll have some time for broader discussion. So he started with the good news, and I want to also start with the good news. I think that's really important. And one of the messages that I like to convey in that regard, and that I don't think we in public health convey often enough, is that the second half of the 20th century has seen the largest and most widespread improvement in human health in the history of the human race. That is a very powerful message. You know, a lot of times people read and watch TV, read the newspapers, and so on, and we're all overwhelmed with the distressing pictures we see around the world. They are distressing, they are disturbing, and there are many awful things. But we are in an era of unprecedented progress, and I really think that message needs to come out, not to reduce the energy to address the problems, but actually to accelerate the energy to address the problems. Because the question that people ask most often about global health work is, are you doing any good? I get that question all the time. That's like a lifetime question. In your life, do you think you've done any good? You know, that's a tough question, right? So I'm not going to tell you my answer, but the world message is yes, a lot of good is taking place. So I think that's a very good place to start. Just to sort of tie that to something more specific, about 2 years ago, a group of economists and public health people led by Larry Summers, who was at one time the chief economist at the World Bank. He was the Secretary of Finance in the United States, our Minister of Finance, President of Harvard, led a group which identified something they called the grand convergence in health that was taking shape. And that was that the era of health issues in low and lower middle income countries being dominated by communicable diseases and undernutrition, we could see the end of that era. We could see that there would be a world in which countries would be converging in terms of the health problems that they will need to address. Now, they said we were going to get there by 2035. I think that was a little optimistic, and as we get closer to 2035, maybe that seems to be the case. But I think the vision is a good one, and that we... now, the good thing is we will see some of this convergence. The not so good thing is we're going to be encountering a whole bunch of new problems that we're all going to be experiencing around the world. Problems of non-communicable diseases, overnutrition, and other things that we all know quite well. So it's not as if, and this is, I think, a universal truth for those of us working in health, we may solve problems, but problems are not going to disappear. We're just going to generate a whole new set of problems. And that's bad news, but the good news for us is that there'll be work for us to do for the future. So the second thing I want to touch on is Dr. Martin raised the issue of institutions and governance, and I think this is really critical and something that we in public health need to pay more attention to. The term governance is widely used. It's not a very well-defined term. Sometimes it's used to mean corruption or removing corruption, but it's really about much more than that. I just want to touch on some of the intellectual foundations here. In the field that I know well, in economics, there's a line of research around what is called institutional economics. And I think an interesting insight from one of the leading proponents of that field, Douglas North, was the distinction between what he called institutions and organizations. And then in some of the work I've been doing, we've been moving a little bit past that to expand it to a third level, what I would call teams and individuals. So think about institutions as the rules of the game, if you will. So the rules surrounding ownership of property, things like intellectual property or physical property and so on, or the rules around how you can use funds for what purpose and so on. Think about the organizations as these large agglomerations of people who are come to exist as ways of accomplishing social goals and objectives, like ministries of health or health authorities or whatever. And then think about the teams and the individuals who actually carry out the work in those organizations. So these three levels, really, of institutional thinking and governance are really critical in health. And there are many interesting examples of this around the world. One of the ones I like to think about is the contrast, and so the contrast, let's say, between some of the states in southern India, Tamil Nadu, maybe Sri Lanka, which comes also from some similar historical background, and the very positive results they've achieved in health, and the states of northern India. Institutions are often quite similar, right? The laws, the rules, and so on. But the way the organizations function within those institutions, very, very different. And that can be traced down to the people themselves and how they work in their organizations. Another interesting contrast that I've experienced working in Africa between some of the real challenges faced in Nigeria to actually get public institutions to perform well, and the work I've been doing the last 6 or 7 years in Ethiopia, where there's a sense in Ethiopia that public servants are just, in my observation, very committed to doing their work. They show up for work on time, they do their jobs, not everyone, but on the whole. And so what explains those kinds of differences? So this is something I think we do need to work on in public health and in global health. Turning to another topic, and I think Dr. Martin raised the question of the SDGs, the Sustainable Development Goals. Worth looking back and thinking about the first part of the 21st century, where we had the Millennium Development Goals, 8 goals that were very much emphasizing very specific targets related to, and 4 of them relating to health and nutrition out of the 8. And now the Sustainable Development Goals, 17 goals and many, many hundreds, I don't remember the exact number, 170 or something, sub-objectives or whatever. I think that the good thing about this transition to this broader set of goals was the wide participation and engagement that led to this very ambitious set of global objectives. But I do think we have to be concerned that this may be a very tall order for the world to address. And recently there's been some writing about this, that, you know, are these goals, given the resources that are forthcoming, too ambitious? And good to have them, but should we be trying to think about more concrete things that we can do going forward? Again, really an institution and governance question globally, okay? Dr. Martin mentioned the recent work from WHO, that aid is not the answer to these problems, and I think that is very much an important truth that we need to acknowledge. In my field, in healthcare financing, we use the term DRM, domestic resource mobilization. It's nice and techy. And there are tools that we have at our disposal to actually try to measure, first, what is needed, and secondly, what is likely to come forward in terms of overall total resource mobilization. Some of this might come from making a bigger dent in corruption and other kinds of loss of resources. But low-income countries, I mean, one of the things that characterizes a low-income country is the difficulty of raising money in the form of taxes. The number of people in the population that you actually can tax, who have an income that is accessible, recordable, and where the organizations can actually reach them, is lower than what we know of in advanced countries. There's been talk about what's called innovative financing mechanisms. We heard a little bit about that yesterday. The concept of the development impact bond was raised, but I think we still need to see whether that can really lead to a large increase in resources. But there's one item on the domestic resource mobilization agenda which I think we have a particular opportunity in public health to play a role in, and that's improving the efficiency of services and service delivery. And it's one that hasn't been given as much attention as it should be. It's very disturbing and almost ironic in a sense that in many low-income countries, services that are available are underutilized. And there is waste in the limited resources that are available. And there's a significant potential gain. WHO estimated in 2015, I think it was, that about 20% that improving efficiency could increase the actual amount of resources for healthcare in low-income countries by more than 20%. Okay? That number wasn't based on a lot of really good research, but it's at least an exciting number, and a 20% jump in your budget is a pretty significant increase, so something worth thinking about. I wanted to say a few words about universal health coverage. You also mentioned that. A beautiful idea, a beautiful goal for the world to assure, as it was originally defined, that all people would receive all the health care they need at a good level of quality without incurring undue financial hardship. It's an ambitious challenge. It's one of the Sustainable Development Goals, one of the goals under SDG 3. Often seen as the goal of SDG 3 by some. And one of the interesting things about it is that it combines what I think of as two core objectives of health systems, which is improving health, but also financial protection, what we call financial risk protection, protecting people from the high cost of health care. In its advancing as an SDG goal, it's been modified a bit, and the world has recognized the ambition of this goal and now talks about universal health coverage with essential or basic services. I don't want to get into the details of what that actually means, but you can see that's a very significant difference from comprehensive, what one might call comprehensive UHC. Many countries are struggling with what this means in practice. And I will say, and this is part of the research that I do, I think we're seeing some of the risks of this more comprehensive goal in low-income countries where there's a significant competition in the use of funds for higher-level clinical services, which account for a large share of the financial risk that families face, because these are costly services, often delivered in hospitals, and the services that are more likely to improve population health, which may include much more of the lower cost services on an individual basis, not that they're necessarily low cost, but these are things like behavior change, health promotion, some of the prevention technologies that we have, and so on. And in several of the countries where I've been working, and one of them and I hope I'll talk more about this maybe later in the year if I have a chance to give some presentations, in Indonesia, which now today, since 2014, has the world's largest single-payer health insurance system. More than 200 million people are covered under a national health insurance program, single-payer system. I know you thought it was Canada, but it's not. And they're seeing real problems where funds are being drawn into higher level clinical services because that's part of the benefits that are promised people, and taking funds away literally from some of the more basic population health improving services. And so I think we're going to see this issue going forward. I think I'll just touch on one or two more things. Politics, Dr. Martin mentioned, very important. I think that the exciting thing in public health is we are this bridge between science and activism, and politics is definitely part of that, but we need to study politics also. We need to study what works and doesn't work in politics. One of my colleagues at Harvard who works on this very much says, the world has talked too much about political will and not enough about political skill. So we need to train people in political skill. And lastly, let me touch a bit on partnerships in global health. I think this is the future. We're not going to see a future of one-way exchange of funds and expertise from wealthier countries to poorer countries. We're going to see collaboration of mutual benefit be much more important in the future. And I think the thing we have to ask ourselves in countries, in the wealthier countries of the world is, why should our citizens, our fellow citizens, why should they support this? Why should they do this? And there are some interesting examples of countries that have been more successful at this. I think the UK is one of those countries. There is a sense of responsibility. Not always, the politics goes up and down, but there's a sense of responsibility. And partially it comes from the very widespread participation of the previous generation of UK citizens in living and working in the rest of the world. So it's kind of I won't talk about colonialism as a positive force in history, far from it, but it's one of the leftovers that may be having some positive effects. Norway, another country that has really picked up its role in the world. Small country, wealthy because of natural resources, but playing an outsized role in global health. So what about Canada is a question that I would like to pose, and I hope to learn more what might be the answer to that question. And certainly in the US, this was a question that we struggled with. Why should American citizens care about these issues? You know, and there was a strong humanitarian reason, and I think the US really stepped up in a very big way in the global HIV/AIDS epidemic, much to the surprise of many of us, that really had resonance amongst the citizens. But in the future, what's going to be the thing that's going to drive that interest? So let me stop there, and I know we'll have a lot of questions and discussions.
I'm going to invite our speakers up front here, and wonderful seeing so many people here. So we're going to start with questions from the audience, and remember I have to run back before our speakers can answer.
Welcome, Keith, Dave, Patrick. Very nice to see you here. The themes that both of you came up with about corruption, the importance of institution building, and Peter, in your last few minutes you mentioned colonialism. Nowhere on the planet has that process of colonialism been more complete than, say, North America and Australia. And I'm just wondering if there are some of the principles that you're talking about that we could draw from as we're working with our indigenous communities here to complete the process of undoing colonization.
Okay, I'll start because then I can let Dr. Martin take the lead. So simple answer, of course, is yes, right? And I think what's really, one of the things that's really interesting or sort of very difficult or problematic about that is that you see how deeply embedded are in North America, and I think with the Native American populations in the United States. Coming out here to Vancouver, my wife and I drove across the country, and we met some friends of friends who are involved in the Native American issues in South Dakota and Wyoming and so on, and we listened to a lot of books on the road about the U.S. history itself, and you see how this is not simply a resources problem. This is something that is deeply embedded in sort of the crisis of cultures that took place in this confrontation, and is transmitted or transmissible across generations, which makes it, in some ways, the colonized countries of the lower and middle income world at least have their nationalism to draw on. So I do hope to learn a lot more about this while I'm here, and how we can contribute. I will add one personal footnote. Some of my early research was on community health workers, and I learned a lot from Canada's northern regions about the experience with that has now really influenced a lot of the thinking about community-based health programs in developing countries.
Thanks, Dr. Berman. Thank you for your question. In global health, Indigenous peoples' issues are MIA, quite frankly. And it's shocking to me to see that we keep on trying to bring it up, but they're nowhere. And Dr. Berman knows as well, whether it's here in the US or in the United States or around the world, Indigenous peoples are not, their issues are not addressed. They have some of the worst healthcare outcomes. They are also their territory is some of the most biodiverse and important ecosystems on the planet. So for us here in Canada, as imperfectly as our history's been and what we've been doing for a long time, we're further along than a lot of countries. And there's an opportunity for us to work with Indigenous peoples, work with Indigenous peoples groups, to learn, listen, share, and work together with them to address the global health challenges they face, including the environmental challenges, in being able to address the interplay between environmental health, sustainable ecosystem use, and human outcomes.
We have an online question, and it's from Erica Frank, who thanks you for the wonderful presentation. The question is, can you please explain how we can support SPPH faculty and students interested in addressing these global health goals?
Oh, okay. So you see this, we've got an unwritten rule here that we're reversing. But so thank you, Erica, for your question. I think that, as I said in my comments, at UBC, and Dr. Berman, and all of you know this, but there's so much going on around the university. I think part of the opportunity is to be able to find a place to bring that disparate work together on some common mechanism so people know what each other are doing, so they can find platforms for collaboration, sharing knowledge, and teaching. So, and there are things that can be seen from other institutions around the world where they've done this well, but I think that is a rate-limiting step to UBC's aspirations, if I may say so, is to overcome the siloing that's taking place here. And you're not alone. Every institution has it to varying degrees, but there's a real opportunity to be able to make the work that you're doing more effective by being able to find a way to bring that together. And maybe the School of Population Health is a place to do that as a neutral actor, to bring together the various disciplines doing work from engineering to business to medicine to nursing, dentistry, social sciences. There are ways to do that, so ways to learn from where others have gone, and that's, I think, an opportunity, a challenge to do that, to Erica's question.
Okay, I'll try to give three quick answers. So one thing which we are, as I've been learning, we are already doing is there are many people in SPPH and in affiliated organizations that create opportunities for students through their own engagement in global health work. And I think that we all I congratulate all of you for what you're doing, and I think we should do more. The second thing, and it touches on what Dr. Martin said, is broadening out the concept of what is global health work. There are many ways to contribute to global health, and they're not just about going out to a lower middle income country and doing work in the field. And I think these associations with other faculties and other fields is another way we can help create those opportunities. And the third is partnerships with organizations in Canada, with organizations globally, and maybe strengthening some strong partnerships with institutions in lower and middle income countries where there'll be exchange in both directions and mutual benefit.
Dr. Berman, you mentioned earlier that we've seen an incredible improvement in human health over the last 50 years. However, I think what is really worrisome about that is that has happened at the expense of the health of the planet that we live on. And to a degree where climate change has actually been described as the threat to global health of the 21st century. So I'm wondering, apart from development of new holistic health research fields such as planetary health, where do you see the roles of institutions going forward in that area?
I can't dodge that one, huh? Okay, thank you. No, I didn't mean to want to dodge it. It's a very good question. I've been thinking about this a lot, and I hope that we can have some exchange of this on this question at SPPH. What is the role of public health in this broad global change, which is worrying us all? And I think one very clear role is really in fleshing out the pathways through which climate change is going to influence human health, right? And the impact of interventions in various ways in which one can reduce the effects, the negative effects of climate change on human health. So that's like our, that's our regular playground, okay? That's what we do here in public health. And I do think that's very important. What I'm not so sure about is how much public health, how big a role public health has to play in actually the global changes that have to take place to mitigate the effects or the causes of climate change. Other than this knowledge and knowledge dissemination role. In other words, we're in public health, we're not the ones who are going to change the use of fossil fuels, or we can contribute evidence and information to that debate, but it's not our core area of activity. So I'd like to think more about that, and I'm not saying that to limit what we do, I'm saying that to be more focused and figure out what are the places where we really should focus our energies in this huge problem.
So in addition to what Dr. Berman said, let me share with you some exciting things that are going on at CUGH. And I would invite all of you to come. We have an annual conference. The next one is March 7th to 10th in Chicago. And there's really three big communities in this space. And Dr. Berman did a great job of speaking about the climate change ones. There's the planetary health, the One Health, and the environmental health. Climate change is one, but we're looking at two big other areas. The destruction of ecosystems broadly defined, right? We're right now, there's something called Earth Overshoot Day. And we measure the amount of ecosystem services that the planet utilizes. And every year, that day is the day that we are using all of what the planet can produce in terms of the ecosystem services we need. And everything beyond that is more than what the planet can produce. That day is moving further earlier. Right now, I think it's at the end of August. Within our lifetime, it was at the end of December. Now it's at the end of August. What's it going to be like 20 years from now? The other area is in biodiversity losses. Now you may think that who cares about biodiversity? But here's the thing. We're in the 6th massive extinction crisis right now on the planet. We have lost 40% of all species on the planet right now. Why is this important? Not only for bees because they pollinate our food, and that's responsible for 50% plus of what we eat, but we're also seeing what's called insect Armageddon. The actual substrate of biodiversity on the planet is being completely lost. We are apex predators on the top. We're completely gutting the stuff on the bottom that's actually vital to our lives. So there's a chance, I mean, this is something really exciting. We're working with the International Union for the Conservation of Nature, because if you look at ecosystem services, one of the great benefits is that it's a huge benefit towards addressing non-communicable diseases. What we don't have, and what maybe Dr. Berman is an economist, which we actually need, we need economists to show the rate of return on investing in ecosystem services that can have a profound impact on NCDs, not only cardiovascular disease, but also mental health, the leading cause of disability in the world. The evidence shows clearly that our environment, spending time out in wild spaces, has demonstrable benefits to addressing what's NCDs causing, which cause 70% of the planet's world's mortality, right? Yet receives only 2% of funding. That's an issue that I didn't get a chance to talk about, but that's a huge chance for all of us in public health to not to take money away from infectious diseases, but to show that there's a benefit. I mean, there's a whole host of stuff that's a whole part of another conversation, from antimicrobial resistance to animal health to a whole lot of other things. But all of that's entwined in this complex area. There's a huge opportunity for public health to actually bring those different disciplines together to deal with it. Sorry for the long answer, but it's like a huge passion. So, and we're doing.
Thanks, Karen. Jerry Spiegel with SPPH, working on a lot of global health issues. So thanks for the presentations this morning. I was glad to see the emphasis in terms of skills and partnerships, because that's something that we're trying to stress as a focus for an undergraduate course that we, Emily and I, are teaching this term in a new course that's coming up. And one of the things we use is the competencies the CUGH kind of puts forward. But we combine that and put more of an emphasis with the principles for ethical engagement to have equity-focused global health research that were developed by a Canadian network, the Canadian Coalition for Global Health Research, that I know you've had some experience. So this is directed primarily to Dr. Martin. As a Canadian who's leading this kind of North American, but primarily US-based network with some Canadian members, what do you see as a fruitful way of partnering with this very rich Canadian network that's dealt with, for example, how we address issues like Indigenous health within a global health framework? What do you think is a fruitful way of working together for this partnership of partners to approach partnership, and maybe other ways that we could share the experience with our US-based colleagues?
Thanks, Dr. Spiegel. Good to see you again. Thank you for your question. So a few great things. So Dr. Charles Larson, who used to be here, is now at McGill. He's on our board. So we tried to find a way to bring Canadian institutions in what we're doing. So we have CCGH, our Canadian representative, on our 15-person board of directors, which is fantastic. So Charles asserts that. And we have obviously a number of other Canadian institutions that are part of this. Barb Astley, who's in British Columbia, chairs our competencies committee. And they've come up with actually a 2.0 version of that. So our subcommittee on competencies has actually reformed and modernized their list of global health competencies. So I think the best way is, a way for us is for UBC to join CUGH, and that gives a platform and a mechanism for our folks here to be involved in the different work we're doing across research, education, service advocacy. We also have a working group on ethics to be able to identify ethical guidelines for ethical collaborations, and a number of other areas. So for example, on law that Dr. Berman mentioned about the legal underpinnings for global health, we actually have a working group on global health law, bringing in some of the best minds in law from Georgetown University and University of Maryland and others to deal with these challenges. We'd love it if we're able to obviously bring our Canadian colleagues in all of the activities we're doing, including, again, coming to our conference in March, which would be great.
So there were a couple of really interesting things that came out of that conversation, and two that particularly struck me were interdisciplinarity and the opportunities for increasing efficiencies in the healthcare system. And I think there's an interesting overlap between those two. So I'm curious for your thoughts around, if you're a global health institution, if you're a global health funder, we typically operate in silos of health, but who would be our in-country stakeholders beyond health that would make the most sense to begin working with to improve operational efficiency? So do we start talking to ministries of finance? Do we start talking to the Ministry of Defense and engaging with, you know, military infrastructure that's there? Something. How do we go outside of just health to improve operations, improve efficiency, and really get to the point where we can build solid public institutions?
Okay, that's a great question and a big question. So I think there are different levels or layers at which we need to think about efficiency. You know, at the and let's focus on countries rather than the global layer. There's also a global layer, but you know, think about how countries consider the weight given to military expenditures versus social expenditures, right? And so at a high level, there's that resource allocation question, right? And making the case at the highest levels of government about the benefits of improving health and health conditions, I think, has not been done very well. It's actually been done better in the global discourse than it has been done at the national level. At Harvard, we've had a training program for ministers of finance and ministers of health and ministers of education. And the first thing ministers of finance say when they're asked, why don't you pay more attention to health, is, well, think about it from my point of view. Everybody comes to me and tells me they need more money. And everybody tells me what they're doing is the most important thing for the country, right? So, and in our perception, the Ministry of Health isn't making that case very well, very persuasively. And when you talk to ministers of health, sometimes they say, yeah, we really don't know how to make that case in a way that the Minister of Finance would understand. You know? And so that's one thing that we could do, help do more of. And then just to, because this is a very long, the answer to this question could be very long. So just to shift from the highest level to a more lower level, there is that question of what actually happens in the healthcare delivery setting, in the district, in the clinic, in the hospital, and so on. And there again, when we look at what's going on in many low and middle income countries, we find that they have developed organizational structures for these activities that have really underemphasized management and other kinds of skills that would improve efficiency, right? And in most of the wealthier countries of the world now, we devote a lot of resources to training and putting in place people who have professional skills in this area. That practice it's not as widespread in the rest of the world. So I think that there are gains at all these different levels and everywhere in between. And I do think in public health, that's a place where we really could contribute a lot more.
And then briefly, because I know we're running out of time, but it's an outstanding question. So here's a few other things for consideration. One is the issue of capacity building for academia to work within NGOs, to be able to engage with governments, not only in health, but also in finance and justice and others, to be able to strengthen those capabilities. Academia doesn't operationalize as much as it truly doesn't. But NGOs have capabilities, obviously, that academia doesn't, and vice versa. So that relationship can be very fruitful. Bringing the private sector, looking at chambers of commerce. You have things they need, right? Research capabilities. Also, they need a healthy workforce. Right? They're also a powerful tool for advocacy to influence governments to do what Dr. Berman's on. They listen to the private sector. Also, don't exclude defense because the defense folks actually understand very well the insecurities taking place abroad. In the US, for example, we use Defense Department research showing that climate change is a clear and present threat to the United States to be able to hopefully influence policymakers to say, you gotta believe us, but you better believe your generals because they're saying this. So that's just part of it, bringing in those other sectors, of the disciplines across NGOs, the private sector, and governments beyond health.
I want to add one more thing, if I could, just very briefly, because I know this is of interest to Jen, and I left it out. So there is also the sort of new invention game changers, which are part of this as well. And you know, we're in an era of incredible health improvement. We're also in an era of incredible technological advance in data science, in genomics, in other fields, which are producing new ideas and solutions, changing the way we do things that we've been doing the same way for a long time. But it is not always the case that these advances can be scaled up to produce the kind of efficiency gains that they could potentially produce. Just didn't want to leave that.
We have run out of time, but our speakers, I'm sure, will be here for the next few minutes. So those whose questions we're not able to answer, please feel free to come up and chat with our guests. And with that, one more announcement, and the next Grand Rounds is March 22nd, and that's on the criminal justice system, just a teaser. So with that, please join me in thanking our speakers for today.
I went to the wrong